Hi, this is Bob Harrington from Stanford University here on Medscape Cardiology and the Heart.org. Thanks for joining us today. One of the topics that's interested me greatly over the course of the last few years has been how we can do a better job of the integration of clinical research with clinical practice. Around the globe in cardiology, we're all very, very interested in both developing evidence that form the basis of practice guidelines as well as collecting evidence within the context of clinical practice to better inform the guidelines along the lines of what's actually being done in contemporary practice. As I have talked several times on this podcast with folks from Sweden, with folks from the U.S. regarding some recent PCORI projects, I often think about the notion of how we can create truly continuously learning systems, or as the American Institute of Medicine has called it, the learning healthcare system. Well, one of the topics that has grabbed certainly my attention, and I think has grabbed the broader interventional community's attention, has been a fabulous trial done out of the UK called HEAT-PPCI, which really, to me, is a great example of how we can learn continuously within a healthcare system and still utilize that not just for the local environment, but to provide generalizable information for the broader community. There were questions raised about the single-center nature of the trial, some of the issues of consent. But during the course of all those discussions, I think that we missed an opportunity as a community to have the broader discussions about how this was an example, a very good example of how we can better integrate research with clinical practice. So I'm really delighted today to have as our guest Dr. Rod Stables. Rod is an interventional cardiologist at the Liverpool Heart and Chest Hospital and the director of the Cardiac Catheterization Laboratory, who was the overall principal investigator of HEAT and who has given a great deal of thought into how one thinks about the integration of research with practice. So, Rod, thanks for joining us here today on Medscape Cardiology.
My pleasure. Thank you.
So, Rod, let's dive right into it and talk about what interests you these days in this notion of integrating clinical research with clinical practice. And what I mean by that is, as a busy practitioner, why do you see this as such an important topic?
Well, I think if you look at the world literature, there's quite an established body of opinion, some might say almost an accepted wisdom, that institutions and physicians who participate in research benefit enormously from the experience, as do their patients. There's good evidence that institutions who are research active will be more aware of changes in practice, more responsive to guidelines, provide better evidence-based medicine. The experience of the way they work in this respect will stimulate and educate and develop their staff. They will recruit and maintain higher quality staff. Their patients may receive more systematic care, more precise care, greater attention to detail. It is possible, of course, that patients may receive more personalized or direct attention. And, even in studies where patients are receiving placebo or double placebo, there's a tendency that those individuals may experience a better outcome than the institutional norm. Now, I think we'd like to feel that we could deliver that for all of our patients and all of our staff on a more or less daily basis, and at the same time make a substantial contribution to the development of the evidence base. And that's got to be a noble vision.
That's his articulately defined view of a learning healthcare system, as I've heard, which is that we're learning continuously, and that continuous learning benefits our patients first, benefits ourselves as practitioners, and benefits the broader community.
Locally, we have to commit ourselves to develop the means locally, the institutional facilities, which will allow us to move towards a vision where we hope all of our patients, every healthcare encounter, in some way will be making a contribution towards well-structured, well-planned research.
Yeah, my former colleague at Duke, Chris Granger, who directs and has directed the Duke Cardiac Care Unit for many, many years, Chris liked to say the same thing, Rod, which is that every patient on every encounter ought to be an opportunity to engage in research because they'll get better care and we'll learn something, and I think you're both right. Let's talk about HEAT first. Not so much from the bivalirudin issue. You and I talked a little bit offline that generated a lot of furor. But let's focus on the structure and the opportunity because I find this one of the most remarkable examples of the integration of research with practice that I've seen in a number of years. Talk a little bit about how you structured the trial, why you structured it that way, and give the listening audience some sense of the commitment of your practitioners, which I find extraordinary.
Well, again, I think most of your listeners, Bob, will be aware of the general knowledge that the vast majority of randomized controlled trials that guide our practice tend to be conducted in relatively few specialized centers and tend to recruit a highly selected population which may not necessarily be representative of the true clinical everyday norms. And I wanted to have a trial which I think may actually be certainly the first trial in cardiovascular medicine, if not the first trial in any branch of medicine, that would recruit every single eligible patient without fail. Now, we were working in the setting of primary PCI, which of course is a pressurized, time-critical environment, a service which operates 24 hours a day, 7 days a week, 365 days a year. And in my institution, we are activated to receive a primary about 1,400 times every year. I collaborate with about 11 other colleagues who share the rota with me on this, and of course a wide variety of other professional disciplines, nursing, radiographic, support staff. And we set ourselves the demanding ambition that every single patient who entered the cath lab in the context of a primary PCI activation would be randomized. Now, people were interested in the general question, but for example, I had two colleagues who favored low molecular weight heparin, which wasn't even one of the substances under evaluation. But their attitude was, the trial's important, it's important to be cohesive, I won't use my normal drug because I'm going to follow the protocol. And I was incredibly moved and proud of the effort that saw 22 months of continuous activity, and nobody missed a single patient. 2 in the morning, 3 in a row, Sunday afternoon, every patient was randomized, and I think that's tremendous commitment.
I hope our listeners really focused on that. 22 months, 24/7, every single patient who was eligible was enrolled into the study. I mean, that is, someone like me who has done clinical trials for 25 plus years now, that's an extraordinary accomplishment. And I did not know that piece about the low molecular weight heparin because that did require dedication. One of the comments that frequently comes up is, well, I'll enroll my patients, but I'm not sure that my colleagues will enroll theirs. How did you get community buy-in so that your colleagues were all willing to participate in the randomized trial? Because clearly, as a community, meaning at Liverpool, you as a group had equipoise. That's what made it ethical to do the study at Liverpool. What was it about Liverpool, the setting you've created, the environment, that your colleagues were all willing to say, we're in 24/7 for the next couple of years?
Well, I'm very fortunate that I work in a wonderful hospital with great colleagues, and we're incredibly cohesive and team-based on everything we do. We make joint decisions about which stock we'll hold and which stock we won't hold, and which trials we'll support and which trials we won't support. And that in the military, the term is called concentration of force. If an institution like ours turns its support towards one endeavor, but does it in a wholehearted, cohesive manner, what your EP colleagues would call synchronous, then you're going to get a far greater effect. And we can bring much more force to bear if we collaborate and cooperate in this way, and that's the key. So we've got other studies to demonstrate it as well. Recently we were looking at a prospective registry study just studying issues of hypersensitivity and allergic reaction with hydrophilic radial sheaths, and we completed a 400-patient prospective study in 50 days. Once a unit mobilizes behind an endeavor, particularly, we do about 2,900 PCIs a year, so we're in a position to mobilize big force when we work together.
Again, you're making it sound easier than we both know it is, but that's an extraordinary ability to get people to work together. Talk a little bit about not your physician colleagues, but you had indicated your radiology colleagues, your nursing colleagues, your support staff colleagues. Same issue here, that people feel part of the whole, and so they're willing to collaborate like this?
We worked out from the software that more than 150 different people actually performed a randomization action. The case record forms were completed in real time by real frontline clinical staff. I mean, things that at the time perhaps seemed mundane and unimportant, eventually, as we got into the furore after HEAT, became incredibly important. So when we were talking about the dosing of anticoagulant agents and their effect, who would have thought that the body weight of the patient would have been so important? But for a weight-adjusted drug, of course, it's critical. And in the primary PCI setting, frequently you don't know the weight of the patient. So we recorded the estimated weight as used in the lab, and 24 hours later, we weighed the patients, and we were able to show data on the accuracy and the spread, and every aspect of the hospital collaborated. I mean, people in clinical coding, we used as audit clerks to check. Clinical coding picked up on one minor bleeding event that we missed clinically in a patient who progressed to bypass grafting, and it was a tremendous hospital-wide effort that was a positive and unifying force.
I know that you're intending, because we talked offline about some of the publications that you have coming forward, some of these methodologic issues will be incredibly important to share with the rest of the community so that we can all learn from the lessons at Liverpool during this. Let me talk about another constituency where there's also been much discussion around the trial, and that's the patients. And I'm on record as having been very much a supporter of the consent methodology that you used in the trial. I think it was innovative. I think it was completely within the realm of how we think about the ethics of clinical trials. But not all in the community agree with you and your approach, or me and my support. Do you want to talk a little bit about the consent process, why you chose to do it that way, and what are the learnings that you've had from now having the benefit of having done the study and talking with patients about their experience? What have you learned, and would you do it the same way?
Well, yes, I would definitely do it the same way, and I am proud and consistent and solid in my belief that we behaved sensibly and appropriately. But of course, there are some caveats that we need to bear in mind here. The first one is that every research endeavor is clearly different and has different nuances as it affects the patients. Now, in our cath lab, before HEAT initiated, both bivalirudin and heparin were available and were in regular use on the basis of physician preference and so on. And that a patient entering the cath lab in the context of a primary PCI could well have had either heparin or bivalirudin, and they would never have been asked or consulted. It would have just been administered on the feelings of the physician at the time. Now, the trial randomized the patients between these two accepted, guideline-endorsed, and well-established products. And as such, there was nothing novel or experimental, and they were not being subjected to anything out of the normal. Ideally the following day, but when patients were at ease and fully recovered, the trial was discussed with them. They were informed what had happened, and we sought their permission then to continue to use the data we'd accumulated to date and to remain in touch with them for the purposes of clinical follow-up. And, you know, although it's obviously a post hoc observation, it's clearly, to me, very positive that only 3 patients out of 1,827 chose not to continue with the trial. And interestingly, although we didn't in any way ask the patients to explain why or to justify their choice, these 3 individuals chose to do so, and they had issues unrelated to ethics and unrelated to the concept of the trial, but more to do with aspects of their personal life. So there were no major ethical issues there. And I think that aspect of the nature of the trial is important in accepting this kind of way forward. The other key issue, of course, is that this was in the context of primary PCI. And again, as you can see from the published paper, we are performance managed on the time interval from ambulance handbrake to artery open, and the median was 29 minutes. Now, there isn't an enormous amount of time for meaningful informed discussion, even if the patient was at rest and compos mentis, but a patient in pain, distress, under the influence of opiates, to discuss the ins and outs of a randomized trial in a handful of seconds it's not what constitutes informed consent. We don't even ask the patients to provide written consent for the primary PPCI itself.
These are terrific issues, which I fully agree with, and I think that you've nicely laid out what the caveats are around the type of research that this kind of design is most applicable towards. And I fully agree with the way that you approach this, although, as I've said, there are people in the community who have not agreed.
But just in the interest of balance, there is, obviously whenever you choose a line, you have to accept its limitations. And I am conscious of one important limitation of the approach we chose, and I just think it's important we share that so that your listeners can hear both sides of the story. The counter-argument which appeals to me is that whilst I think most reasonable observers would accept that it would be impossible for a patient to provide truly informed, reasoned and meaningful consent in these circumstances, I can accept that the converse may be true. Let's imagine a patient has a preformed view that they would never, ever, ever, under any circumstances, wish to participate in a research endeavor. In the same way they may choose never to donate a kidney or to, they hold similar strong views on a variety of issues. You could imagine a scenario where a patient, even in a primary PCI setting, given the chance, could express this preformed intention not to participate, and that the HEAT approach denied those patients that opportunity. Now, this is a limitation, and we have to weigh up whether or not it's such a significant limitation that it overtakes the potential advantages.
I accept that as well, and I've heard people articulate that. It brings up the notion of distributive justice as an ethical principle, and oftentimes in clinical trials, I think that the very selective nature of how patients enter the trials in some ways goes against the principle of distributive justice, that we're being too highly selective. And one of the things that appeals to me about the HEAT design is that you're very, very much adhering to the principle of justice because you're including everybody. But I fully accept, as you say, that there may be people who would not want to participate. Did any of that come out, Rod, as you came back to patients a day later? Did you get people? I realize this is not a quantitative exercise, but perhaps a qualitative exercise where people may have expressed discomfort. And did you have a mechanism by which you could capture that information a day later?
No, we didn't really. And again, the consents were captured by a team of initially 3 and in the height of the trial, 5 individuals who were trained for this purpose. We didn't database anything more than the outcome, and I've already hinted the outcomes were very positive. So I don't think it was a major problem. But again, there's a lot on our side here about the nature of the trial, the nature of the setting, and so on. It could be very different if we try to extend this too much.
Now, Rod, one of the things we talked about offline before we went live in recording was a study that you've been doing, which is looking at the mechanism or the method of follow-up. I find this intriguing as somebody who has designed a lot of trials and particularly focused a lot on endpoint ascertainment, adjudication, etc. You've had some unique experiences in this trial to look at different methods of follow-up. You want to comment on that?
Yep, certainly. Anyone who's run a trial, whether it be local or multinational endeavor, will know that a disproportionate amount of the resources, both fiscal and human, is expended on trying to obtain the follow-up. And that if it was possible to obtain similar quality with reduced effort and reduced costs, this would make research much more acceptable. And we were interested in exploring these issues. So in HEAT, we performed what might be regarded as traditional gold standard follow-up with individual personal contact with every patient during the follow-up duration. But at the same time, we also downloaded the information that was available through UK routine computerized health records about hospital admissions. Now, if I can just flick away here, and I'm just going to ditch the question of adjudication and clinical endpoint committee, because I actually do believe in that. I'm very positive about that. But before you get to that stage, the investigators have to know that the patient has experienced some kind of issue or event, and usually the trigger is hospitalization, shall we say. And we start off by asking the patients, have you visited and spent a night in a hospital since your discharge on such and such a date, and so on. Now, what we found was that, in the end, the results that we published in the main paper in the Lancet were actually the product of the synthesis of both methods, because we rapidly realized that the so-called gold standard was wrong, and the computerized method had errors, but they were different errors. So that, for example, a patient would look you in the eye and swear blind that they had never been hospitalized in the follow-up period. And we would later find a computerized record suggesting they had been, and when we went to that institution and sought the medical record, indeed they had been, and an event had occurred. So traditional follow-up would have underestimated the events. And of course there were computerized records suggesting a medical diagnosis that turned out to be wrong and was adjudicated as such later. But the magnitude of the error was approximately equal in both limbs. And so our broad, simple conclusion is that the headline conclusions of a trial would probably look very similar if you simply chose the computerized method over traditional MELOP. And I think this is a really interesting zone to be moving into.
A lot of us are in the U.S., we're spending a lot of energy working with PCORI trying to understand how to best utilize electronic health records to do clinical studies, in particular to do randomized clinical trials, and these same issues come up over and over. And I think as we all share information with each other on the methods, it's going to be enormously valuable for all of us. Rod, final word I'd like you to comment on is maybe the training issues, the training of research fellows, the training of interventional cardiologists during the course of the trials. You actually probably had a couple of classes of fellows come through during the course of the trial. What do you see the role of trials like this for the trainee to be able to learn from, to be part of, and what they can take away?
Well, I think the general learning experience of participating in research is fantastic, but it's not enough simply to do the mechanics on the shop floor every day. You need to back it up with education, seminars, understanding. And this brings us back to where we started, really. The buy-in of an institution hinges on belief. And the belief is based on the fact that you believe the trial is worthy and noble and ethical, but also you believe that it's methodologically sound and that you're engaged with what you're doing and why you are doing it. And we provided continuous feedback seminars, newsletters, posters. The posters were kind of location specific. So the posters in the ambulance receipt area were about eligibility, and the posters in the cath lab were about dosing and blood testing and ACT, and the posters in the ward were about follow-up observations and schedules and blood test schedules, and that this creates the kind of learning environment that I think we're both looking for.
Rod, that is a terrific description of how to engage trainees in research, and I totally agree with you. There's both a didactic and an experiential piece of training and research that's absolutely critical. And it sort of, as you say, brings us back to where we started, which is the real issue that you've highlighted in your work, which is how to integrate research into practice. And so I think we've had a terrific discussion. I want to thank you. My guest has been Rod Stables, who is an interventional cardiologist in Liverpool and the director of the cardiac cath lab there, and really has been doing some very innovative work around this notion of integration of research and practice. Rod, thank you for joining us here today on Medscape Cardiology.
Thank you. It's been a pleasure.